You know, you usually expect a failing machine to be really loud. I mean, if your car engine starts knocking or smoke starts pouring out from under the hood or your laptop screen flashes some fatal error code, the failure pretty much demands your immediate attention. It's unmistakable.
Yeah, totally. I mean, mechanical systems are actually designed to fail loudly. It's a built-in safety feature,
Yeah,
so you can intervene before there's a catastrophic breakdown.
right. But the most vital machine inside you, the human heart, it doesn't always play by those rules.
No, it really doesn't.
So today, welcome to our deep dive. We are pulling apart the mechanics of the cardiovascular system using some incredibly detailed medical textbook chapters on cardiology. And our mission today is to understand a pretty terrifying paradox.
It is terrifying, yeah.
Cardiovascular disease is the leading cause of adult death in the Western world. It claims the lives of roughly a third of all men and a quarter of women in the UK alone. Yet, I mean, think about this. An organ that beats 100,000 times a day, circulating thousands of gallons of blood, it can just quietly degrade for decades without making a single sound.
Yeah, it's often completely silent until it reaches a really advanced stage.
Exactly. So we're going to explore how that silent failure happens, how doctors use basic physics to diagnose it without, cracking your chest open, and what actually happens on a cellular level when the heart simply stops.
And to truly grasp how it breaks, we really have to look past the basic idea of the heart as just a generic pump. We need to examine the sheer mechanical perfection of how it operates on a normal day, because we're looking at a highly optimized dual-engine system.
Right, and most of you listening probably know the basic geography here. The right side handles the oxygen-depleted blood heading to the lungs, while the much thicker left side pushes the oxygen-rich blood out to the rest of the body.
Exactly. But the real engineering genius, well, it's in the pressure gradients. I mean, the right side is essentially a low-pressure, high-volume system. It only really has to push blood a few inches into the pulmonary bed.
Which isn't very far.
Right. But the left side, however, that is a high-pressure resistance pump. It has to generate enough force to push this viscous fluid against gravity, all the way up to your brain and down to your toes, and then get it all the way back.
So it's doing a lot more heavy lifting.
Oh, absolutely. And the architecture reflects that functional difference. The left ventricle's muscular wall is massively hypertrophied, just way thicker compared to the right, precisely to overcome that systemic vascular resistance.
It makes me picture it like a highly efficient, self-contained house. I mean, you have this complex mechanical plumbing system, right? The valves acting as one-way doors, the coronary arteries serving as the dedicated fuel lines to feed the muscle itself.
That's a great analogy, yeah.
But none of that mechanical plumbing functions without flawless timing, and that is entirely dictated by the heart's internal electrical grid.
The conduction system. And this is where the biomechanics get truly fascinating. So the primary pacemaker, the sinoatrial or SA node, it sits up in the upper right chamber.
Okay.
And when it fires, an action potential sweeps across the atrial muscle cells. But nature actually faced a huge design problem here. I mean, if an electrical signal travels freely, it moves incredibly fast.
Right.
So if the signal swept through the entire heart instantly, all four chambers would just contract at the exact same millisecond.
Oh, wait, which would be functionally useless, wouldn't it? Like
Yeah.
the atria and the ventricles would just be wrestling over the same volume of blood.
Exactly. They'd be slamming the valves shut against immense pressure and completely stalling the forward flow. It would be a hydrostatic disaster.
So how does it avoid doing that?
Well, the solution is the atrioventricular, or AV node. As the electrical wave moves down from that SA node, it hits a layer of fibrous, non-conducting tissue that separates the top and bottom chambers.
Oh, like an insulator.
Yeah, exactly like an insulator. So the only way through is this AV node, and its cellular structure is specifically designed to conduct electricity very, very slowly.
Ah, so it acts like an electrical toll booth. It intentionally delays the signal by, what, a fraction of a second?
Yes, exactly a fraction of a second. And this is what allows for the atrial kick. The top chambers squeeze, and they physically top off the ventricles with that last 20% of blood volume.
So they completely fill up.
Right. And only after the ventricles are totally primed does the AV node release the signal down the bundle branches, which triggers the massive ventricular contraction. So it's squeeze top, perfectly timed pause, squeeze bottom.
Wow. Squeeze, pause, squeeze. That millisecond delay must be what maximizes the ejection fraction, right? The sheer volume of blood pushed forward with every single beat.
It is. It really is a masterpiece of evolutionary engineering.
It's incredible. But, mechanical plumbing can only function if that electrical timing is flawless. And that's where the diagnostic window really opens up. I mean, if the heart is a closed house, how do cardiologists inspect the plumbing and the wiring without tearing down the walls?
Well, they have to look for external clues that reflect those internal pressure and electrical states. And one of the most elegant examples of this in the source material is the physical examination of the jugular venous pulse, or JVP.
Okay, the JVP?
Yeah, we're essentially using the fluid dynamics of the body's own venous system as like a liquid dipstick for the right atrium.
A liquid dipstick. Wait, because the internal jugular vein in your neck runs straight down into the superior vena cava, which dumps directly into the right atrium, right?
That's right.
And crucially, there are no valves between that vein and the heart chamber.
Exactly. It is a continuous, uninterrupted column of blood. So if you recline a patient at, say, a 45-degree angle, you can actually observe the pulsation of the internal jugular vein just beneath the skin of the neck.
Oh, wow. So you can literally see it beating.
You can. And when the right ventricle begins to fail, maybe due to lung disease or an old heart attack, it struggles to push blood forward. So fluid backs up and hydrostatic pressure builds in the right atrium.
And that pressure just transmits straight up that valveless column of blood into the neck.
Precisely. By simply measuring the vertical height of that engorged vein above the sternum, a physician can calculate the central venous pressure with remarkable accuracy.
That is wild. You can literally see the heart drowning just by looking at a vein in the neck. That perfectly translates internal pressure to the outside. But doctors also translate internal fluid dynamics into sound, right? Using a stethoscope.
Yes, auscultation. And when we talk about auscultating heart sounds, we aren't just listening for a simple heartbeat. We are listening for turbulence.
Turbulence, like on an airplane?
Sort of, yeah. I mean, fluid physics dictates that blood should flow in a laminar pattern. Laminar means smooth, silent, parallel layers moving through a wide, clear vessel. But structural heart disease disrupts that laminar flow. Take a condition like aortic stenosis, for example, where the aortic valve becomes calcified, stiff, and really narrowed.
Right, so the powerful left ventricle is trying to eject its entire volume of blood through an opening the size of a pinhole instead of a wide-open door.
Exactly. And pushing fluid at a high velocity through a narrowed orifice dramatically increases its Reynolds number. That transitions the flow from smooth to chaotic.
The blood starts swirling.
It swirls, it creates eddies and these violent currents. And that turbulent kinetic energy physically vibrates the surrounding tissues. That vibration travels through the chest wall as acoustic energy, which we hear as a murmur.
So the physician is actively listening to the physics of failing fluid dynamics. That is fascinating. So physical exams read the plumbing. But to read the electrical grid, you need an electrocardiogram, right? The 12-lead ECG.
Yes, the ECG is essential.
And most of you have probably seen an ECG strip at some point. You know, the little bump of the P wave, the flat pause, the massive spike of the QRS complex, and the final T wave.
Right, and we know the P wave is the atria firing, the QRS is that massive ventricular contraction we talked about, and the T wave is the tissue resetting.
But here is the mechanism I really want to dig into from the text. If the ECG measures surface voltage on the skin, it must be reading the aggregate vector of all those cells firing.
Correct.
So when someone has a myocardial infarction, a heart attack, or a coronary artery is blocked, how does the electricity on the skin actually tell doctors that the physical tissue underneath is dying?
That touches on fundamental cellular electrophysiology. See, healthy heart muscle tissue conducts electricity because it has plenty of oxygen to produce ATP.
The energy currency of the cell.
Exactly. That ATP powers the sodium-potassium pumps on the cell membrane, which maintains a highly specific electrical charge across the cell wall.
Yeah.
But when a coronary artery gets blocked, that segment of muscle is suddenly starved of oxygen.
So the ATP production just crashes.
It crashes entirely. The pumps fail, and the cell loses its ability to maintain its resting membrane potential.
Wow. So what happens to the electrical signal then?
Well, the dying cells begin to leak ions. They can no longer depolarize and repolarize normally. And this creates a really stark electrical gradient between the healthy, oxygenated tissue and the suffocating, dying tissue. We call this phenomenon a current of injury.
A current of injury. Because the dead zone can't conduct the normal electrical wave, the current has to, take a detour around it.
That is exactly it. It detours. And the electrodes on your chest pick up that detour. This is what causes ST elevation.
Oh, right. You hear about that all the time.
Yeah, the segment of the ECG tracing between the S wave and the T wave usually rests completely flat on the baseline. But because of that current of injury leaking from the dying cells, the baseline physically elevates on the graph.
So it's an immediate glaring red flag on the paper.
Yes, and sometimes you also see deep Q waves, which indicate actual necrosis or dead tissue that the electricity is just looking straight through. And because a 12-lead ECG uses multiple electrodes to look at the heart from 12 different anatomical angles, it functions almost like a 3D radar system.
That is so cool. So if the ST elevation only shows up in the leads looking at the inferior wall, the doctor knows instantly that the blockage is in the right coronary artery.
Precisely. The electrical squiggles literally pinpoint the exact location of the plumbing failure in real time.
It is just brilliant detective work. But an ECG is looking at an organized system that is damaged. What happens when that highly organized electrical grid doesn't just detour but completely disintegrates?
Well, then we have to shift from diagnostic theory to the acute chaotic reality of a cardiac arrest.
Right, and cardiac arrest is defined as the sudden, complete cessation of cardiac output. The heart just stops pumping entirely.
It does. And while there are several causes, the most notorious electrical catastrophe we see is ventricular fibrillation, or VF.
Okay, so in a healthy heart, the SA node acts as the central command, sending one clear signal. But my understanding of VF from the reading is that the central command is completely hijacked. The electrical synchronization breaks down, and thousands of individual muscle fibers, or ectopic pacemakers, just start firing off their own action potentials at random.
That is a very accurate picture. It is pure electrical anarchy. The ventricles are receiving hundreds of conflicting rapid-fire commands simultaneously.
So there's no coordinated squeeze.
Not at all. Because there is no coordinated depolarization, there's no coordinated mechanical contraction. The heart muscle simply writhes and quivers.
The textbook describes it as looking like a bag of worms.
Yeah, it's a very grim but common clinical description. And because the muscle is just quivering, the ejection fraction drops to absolute zero. No blood leaves the heart.
Meaning the brain is deprived of oxygenated blood immediately.
Right. The patient collapses within seconds.
Which brings us to the chain of survival outlined in the text. Early access, early CPR, early advanced life support, and crucially, early defibrillation. But okay, we really need to dismantle a massive pop culture myth here.
Oh, I know exactly what you're going to say.
If you've ever watched a medical drama, you've seen a patient's heart monitor drop to a flatline asystole. The dramatic, continuous tone plays, the doctor yells, "Clear!" slams the paddles onto the patient's chest, shocks them, and suddenly the rhythmic beeping returns.
Oh, yeah.
The physical reality of defibrillation does not work that way at all, does it?
It absolutely does not. Treating a flatline with a shock is fundamentally contrary to all resuscitation science. Defibrillation is specifically designed for what we categorize as shockable rhythms, and ventricular fibrillation is the primary target there.
Because in VF, there is an abundance of electricity. It's just completely disorganized.
Exactly. The purpose of the defibrillator is not to jumpstart a stopped heart. It is actually designed to stop a chaotic heart.
Wait, to stop it?
Yes. The machine delivers a massive, synchronized dose of electricity that simultaneously depolarizes every single cell in the myocardium. It forces all those chaotic, misfiring cells into an absolute refractory period at the exact same moment.
So you are intentionally stunning the entire organ. It's like, it's the biological equivalent of holding down the power button on a frozen computer to force a hard reset.
That is the perfect analogy. You shut everything down, hoping that when the system boots back up, the SA node, the natural central command, will wake up first and regain control of the rhythm.
Wow. But if a patient is in a systole, a true flatline, there is no electrical activity to reset.
Right. The cells have exhausted their energy stores, and there is no chaotic firing to override.
So shocking a flatline would be like trying to reboot a computer that has been completely unplugged from the wall. It accomplishes nothing.
Worse than nothing, actually, because it wastes vital time. For a systole, the protocol dictates continuous, high-quality chest compressions to manually force blood through the system, combined with vasopressors like epinephrine.
Oh, to keep the pressure up.
Exactly. You are trying to artificially generate enough vascular tone and cellular perfusion to coax the heart muscle back into a state where it might generate an electrical rhythm. Only if a shockable rhythm appears on the monitor do you actually reach for the defibrillator. The Hollywood clear on a flat line is pure fiction.
That is so good to know. So a cardiac arrest is a sudden, dramatic electrical collapse. But the bulk of cardiovascular mortality doesn't actually come from a sudden stop. It comes from a slow, grueling decline.
Yes, unfortunately.
And the mechanism of this chronic failure triggers a biological response that is, honestly, one of the most fascinating and tragic processes in the human body.
You were referring to the pathophysiology of chronic heart failure.
Yes, heart failure is a clinical syndrome where the heart's output is simply insufficient to meet the metabolic demands of the body's tissues. This could be because the left ventricle is heavily scarred from a massive heart attack 10 years ago, or, maybe because the muscle has grown incredibly stiff from pumping against untreated high blood pressure for decades.
Right, the pump is weak.
But it's how the rest of the body responds to that weakness that actually accelerates the disease.
It is. See, the body has incredibly sensitive monitoring systems. You have baroreceptors in your carotid arteries and aortic arch that constantly measure stretch and pressure. And you have a specialized cluster of cells in your kidneys called the macula densa, constantly measuring the flow of sodium and fluid.
Okay, so sensors everywhere.
Right. So when cardiac output drops because the heart is failing, these sensors detect a drop in pressure and perfusion.
And the body completely misinterprets the data. I mean, to your ancient biology, a sudden drop in blood pressure and organ perfusion usually meant one thing. You were bleeding out.
Yes.
If an early human was attacked by a predator and lost a massive amount of blood, the body had to deploy extreme aggressive countermeasures to maintain blood pressure to the brain, or they would die in minutes.
So the body basically goes to war. The first immediate response is the activation of the sympathetic nervous system. The brain floods the bloodstream with catecholamines, adrenaline, and noradrenaline.
Which we feel is that fight or flight rush.
Exactly. And these bind to beta-1 receptors on the heart, essentially whipping the organ, demanding it beat faster and squeeze harder to compensate for the perceived blood loss.
But the body doesn't stop there. It deploys a slower, even more powerful weapon, the RAAS cascade, the renin-angiotensin-aldosterone system.
A very powerful system, yeah. When those kidney sensors detect low flow, they release an enzyme called renin. This kicks off a complex chemical chain reaction in the blood and the lungs that eventually produces a hormone called angiotensin II.
And angiotensin II is one of the most potent vasoconstrictors known in human biology. It forces the smooth muscle in the walls of the arteries all over the body to clamp down violently, artificially driving up blood pressure.
And then comes the final blow. Angiotensin II triggers the adrenal glands to release aldosterone.
Right, I remember reading about this.
Yeah, aldosterone orders the kidneys to stop producing normal amounts of urine. It forces the kidneys to aggressively reabsorb sodium, and where sodium goes, water follows.
So the body just starts hoarding gallons of extra fluid in the venous system, trying to boost total blood volume.
Exactly. And in the context of hemorrhagic shock-like, literally bleeding out, clamping the vessels, holding onto fluid, and spiking adrenaline are brilliant evolutionary survival mechanisms.
Yeah.
They keep you alive long enough for a wound to clot.
But the tragic irony of chronic heart failure is that the patient isn't bleeding. Their heart is just exhausted. The pump is already struggling to move normal volumes of blood.
Right.
So by clamping down the arterial blood vessels, the body drastically increases the systemic resistance the left ventricle has to push against. And by hoarding extra fluid, the body is dumping massive excess volume into a right ventricle that is already backing up.
The compensatory mechanisms create a catastrophic, vicious cycle. It's like taking a horse that is already exhausted and stumbling, whipping it mercilessly, loading more and more bricks onto the cart it's pulling, and then dragging it up a steeper hill.
Wow, that is such a vivid image.
It really is what's happening. The heart dilates, the muscle fibers stretch beyond their optimal length, and the failure accelerates rapidly. The body's desperate attempt to save itself actively destroys the very organ it relies on.
Which fundamentally dictates how modern cardiology treats heart failure. Because for a long time, early medicine tried to treat heart failure with drugs called inotropes medications designed to make the heart squeeze harder.
Yeah, they basically just whip the horse harder. And patients felt better for a few months, but their long-term mortality actually skyrocketed. The heart just burned out faster.
So what changed?
The paradigm shift in cardiology was the realization that to save the failing heart, you have to chemically override the body's ancient survival instincts. You have to stop the body from helping.
Stop it from helping. And you look at the cornerstone medications for heart failure today, and they map perfectly onto blocking those exact systems we just talked about.
They really do.
You have diuretics. These literally force the kidneys to dump the excess sodium and water into the urine, draining the massive fluid overload and basically unloading the bricks from the cart.
Exactly. And then you have ACE inhibitors. These drugs specifically target that RAAS cascade, blocking the enzyme in the lungs that creates angiotensin II. By neutralizing angiotensin II, the arteries relax and widen. The resistance drops, allowing the weak heart to pump forward much more easily.
And crucially, you have beta blockers. I found this part so interesting because for years, doctors were terrified to give beta blockers to heart failure patients because they actively slow the heart rate down and reduce the force of contraction.
Right, why would you ever slow down a weak heart?
Exactly. But we learned that beta blockers act as physical shields. They cover the receptors on the heart muscle, protecting it from the toxic, constant bombardment of the body's own adrenaline. By slowing the heart down, you reduce its oxygen demand and give the exhausted muscle time to recover.
It's amazing. We use pharmacology to trick the body into standing down from a fight that doesn't exist. That breaks the vicious cycle and allows the heart to remodel and actually heal.
It is a profound shift in perspective. I mean, we started this deep dive looking at the heart as a magnificent dual-engine pump, really appreciating the exquisite millisecond timing of the AV node delay that allows fluid to move so efficiently.
And then we explored how cardiologists act as diagnostic detectives, reading the hydrostatic pressure in a neck vein or decoding the electrical detour of an ST elevation to pinpoint dying tissue.
Right. And we dismantled the chaotic electrical anarchy of ventricular fibrillation, establishing exactly why a defibrillator is used to reset a quivering heart, but is absolutely useless on a flat line.
Yes.
And finally, we uncovered the tragic irony of heart failure, where ancient survival reflexes become the very mechanism of our own destruction. So the next time you check your own pulse after a run or, feel your adrenaline spike during a stressful moment, consider the immense complexity of the systems keeping you alive.
It really gives you a new appreciation for it all.
It does. Understanding these mechanics demystifies the primary cause of mortality in the modern world. It explains why managing blood pressure is so critical to reduce the resistance your heart faces every second of every day. And it explains why learning basic CPR isn't just a good idea, it is the literal physical bridge that keeps oxygenated blood flowing to a brain when the body's electrical grid crashes.
Because when disease operates silently for decades, understanding the physiological reality of how your body functions is the strongest defense you have.
Absolutely. And that leads to a final, somewhat unsettling thought to leave you with today. We explored how the body's primal response to a failing heart-retaining fluid, clamping down vessels, flooding the system with adrenaline, is an evolutionary adaptation meant for trauma, not chronic disease.
Right, the mismatch.
Exactly. It perfectly highlights an evolutionary mismatch. It makes you wonder, in what other ways are our primal ancient reflexes completely out of sync with the realities of modern human life? How much of modern illness is simply our biology fighting a battle that no longer exists? Keep questioning the mechanics of everything around you. We'll catch you on the next deep dive.